Trigger finger, also known as stenosing tenovaginitis or tenosynovitis, is a painful hand condition due to inflammation of the flexor tendon sheath. Sometimes the tendon will be too swollen and a nodule is formed. When the nodule passes through the A1 pulley, which is connective tissue that hold the tendon against the bone, it will cause a sudden release or locking of a finger during flexion or extension. And that's why it is called trigger finger. Trigger finger has a range of clinical presentations, and according to the symptoms, this condition can be classified into 4 grades. Patient may experience catching and locking. In the most severe grade, the finger is flexed and cannot be opened up. Other possible symptoms includes palpable nodule proximal to A1 pulley, stiffness especially in the morning, and pain that may radiate to the rest of the palm or digit. The incidence rate is 28 to 100,000 per year. It equals to a lifetime risk of 2.6% in the general population. Risks increases to 10% in the diabetic population, as they may require longer recovery time, leading to a longer disease duration. The mean age of onset is 58 years old, and it is diagnosed in women up to 6 times more frequently than men. It can happen in any fingers, but the thumb and 4th digit are most common.
Trigger finger is usually classified as an idiopathic condition. Some researchers propose that prolonged finger flexion may be the cause, for example, carrying shopping bag or a briefcase. Prolonger writing. Rock climbing. Strenuous grasping of small tools. Other potential risk factors include rheumatoid arthritis, diabetes mellitus, etc.
So how can we diagnose trigger fingers? Let's take a look at the overview of diagnosis. Diagnostic assessment can be basically divided into subjective and objective. Physiotherapists can begin with subjective assessments. Subjective assessment refers to the patient's self-reported problems and feelings about their symptoms, history, impairments and functions. For example, the patient may say,
"I started having trouble with my thumb about 2 months ago. It was not that painful at the beginning. However, it started to get worse. Every time I close my hand, it will lock and I have to use my another hand to open my finger. I couldn't use a knife or fork. If I am making dinner, I have to open up my finger 20 times within 1 hour. And my palm is really painful."
After listening to the patient's complaint and history, we will know that the signs and symptoms are intermittent finger locking during active flexion that requires a passive force to extend the finger. These symptoms are obvious and the patient is suspected to have trigger thumb. After that, objective assessments can be done to further confirm the diagnosis. Regarding physical diagnosis, we can do palpation, special test, assess the range of motion, grip strength, and joint mobility.
Palpation and special test can be done together. To do the special test, physiotherapist can ask the patient to close and open hands for 10 times. During the test, physiotherapist can use their thumb to press on the A1 pulley of the affected digit. You can feel that the nodule sliding right under your thumb during flexion and extension of fingers. The nodule is usually painful to the patient. Occasionally, there will be mechanical locking. Note that in this episode, when the patient try open her hand, the finger is locked. If you open it manually, it will be very painful. The number of locking in 10 active full fists is then scored out of 10. The higher the score, the more severe the symptom. If the finger remains locked all the time, the test is completed and the score will be 10.
The 2 relevant muscles are flexor digitorum profundus and flexor digitorum superficialis. These muscles affect the grip strength, which can be measured by Jamar dynameter. The grip strength varies with sex and age. The normative grip strength are presented in the following table.
Other than physical diagnosis, medical diagnosis including MRI and ultrasound can also be done. MRI and ultrasound are useful for differential diagnosis, as the finding of locking digit is not unique to trigger finger. It can also be associated with dislocation, Dupuytren's contracture, focal dystonia, etc. Complaints of pain in the MCP joint pain could be associated with de Quervain syndrome, ulnar collateral ligament injury, MCP joint sprain. MRI can show good contrast of soft tissue and small structures with more details. In MRI of trigger finger, the key feature is the thickening of the A1 pulley. Image A and B show the thumb MRI of a 72-year-old man with suspected trigger thumb. Figure A is a sagittal T2 weighted MRI of the thumb. Figure B is a transverse T1 weighted MRI of the same thumb. In both image, the black arrowhead show edema and enhancement of the A1 pulley at the MCP joint, and the arrow show mild flexor pollicis longus tendinosis. This MRI finding supports the diagnosis of trigger finger. Compared with MRI, ultrasound is convenient, fast and inexpensive. It enables an accurate static and dynamic evaluation of trigger finger as well as a comparison with the adjacent normal digits. It can be considered as first radiologic modalities for diagnosis, same as MRI.
the key feature of trigger finger in ultrasound is also A1 pulley thickening. Ultrasound can also measure the thickness of the pulley as and constantly monitor the progression of the disease. Pulley thickness over 0.62 mm is considered abnormal. This is a color Doppler ultrasound of trigger finger. This image shows the transverse section of A1 pulley. The white arrowheads shows thickening and hyperemia of the pulley. It also shows flexor tendinosis. The 4 sonograms on the left shows proximal to distal transverse section of the trigger finger. The right 4 images shows normal fingers for comparison. On the left, the white curved arrow shows synovial sheath effusion. On the second row, the arrowhead shows the hypoechoic thickening of A1 pulley. Black arrows show thickening of the flexor digitorum superficialis tendon due to tendinosis. Let's move on the medical management. Non-steroid anti-inflammatory drugs are given to patients for pain relief. Also, corticosteroid injection can reduce inflammation and pressure on the tendon, leading to better gliding through pulleys. However, the effectiveness of corticosteroid injection decreases with the number of injections and increased duration of symptoms. Surgery release is the ultimate treatment. Rarely, if inflammation happen on A2 or A4 pulley, surgical release of these pulleys will cause bowstringing and is not recommended. Surgery is associated with higher costs and a lot of other complications. In fact, most cases can be managed with non-invasive therapy. In physiotherapy management, the patient should rest and modify daily activities. They can seek help from others, take rest between tasks or change ways of doing a task like the following pictures. In addition, splinting can be used to limit activities of finger to prevent worsening of condition. Splints can be worn at the MCP or dip joint. Splinting at MCP joints shows higher rate of symptoms resolution. Subject comfort with the MCP joint blocking splint allowed for longer periods of usage and better patient compliance. Splints can be worn for 6 to 10 weeks. For severe or long duration of symptoms, splinting has a lower success rate. Regarding other modalities, ultrasound therapy is also effective. It can increase lymph and blood flow to inflamed area, reduce inflammation and promote blood flow.
There was no recurrence of pain or triggering at all in patients who were successfully treated with physiotherapy after 6 months post-treatment. Other than ultrasound, extracorporeal shockwave therapy can be applied. Shockwaves are sound wave that have high peak pressure, and can maximize the pressure of target tissue over a few nanoseconds. In comparison to ultrasound waves, the shockwave peak pressure is approximately 1,000 times greater. This therapy was first used to treat kidney or urinary stones. In later studies, it was shown to promote tissue repairment. It also works by stimulating the synthesis of nitric oxide, which suppress inflammation, and increase angiotensin factor, leading to neovascularization, leading to increased blood supply, promote tendon healing. In a research comparing the efficacy of corticosteroid injection and shockwave in patients with triggering but actively correctable fingers, it was shown that shockwave is as effective as injection for improving functional status and severity. Also, the complication is low and negligible. It may be suitable for people who have needle phobia, or want to avoid complications of injection. In the chronic stage, as the inflammation and pain subsided, patient can start home exercising program. The first one is stretching, or passive finger extension. The second set of movement is tendon gliding, which can reduce adhesion of the inflamed tendon. The third set of movement is adduction and abduction. It can strengthen the lumbricals and interossae. Deep friction massage can be used to mobilize the tendon and reduce adhesion and inflammation. First, locate the painful nodule at the base of the affected finger. Then, apply a firm pressure to massage the nodule in a transverse left and right direction. The same thing can be done with the base of a pen. To conclude, trigger finger is caused by the inflammation of the tendon. Some researchers suggest it may be caused by repetitive finger flexion. The classical presentation is catching and popping on the finger. Most cases can be managed by physiotherapy. Physiotherapy management include ultrasound therapy, shockwave. To prevent trigger finger, avoid repetitive hand flexion and take rest between tasks.